Ma'am, your presentation was visible.
Yeah.
So for the slide sharing, yes. Perfect now.
It's okay. So, good afternoon to all the participants. So, today we are going to have stoma care. So, I'll be just going with colostomy care first, then we'll just have a look at the tracheostomy care also. Okay. So when you talk about the definition, it's an artificial opening into a section of colon, which is brought out through an opening in the abdomen. Usually it's a stoma. I will show you. See, this is what we can. Okay, and this word is derived from the word, a Greek word meaning mouth. So stoma means it is just mouth. You can see the different types. You see, previously people were not having any, what to say, colostomy bags to be used. So this is what they were using. So this is another type of bag. This is another type of bag which is available now in India also. Our main aim is to care for the patient to achieve the maximum independence and regain a high quality of life. So we are focusing that the patient should be independent and of course improve the quality of life. So usually they will, this is how they will look. So we have input ostomy, we have output ostomy. Input ostomy, when we talk, it is like tracheostomy, gastrostomy, and feeding ileostomy. Input means which goes inside, output ostomy means which comes from inside out. So usually it is the fecal matter, urine and all. So that is called colostomy, urostomy, or ileostomy. So when we talk about the types, according to duration, it is temporary or permanent. Temporary, people know. It is temporarily done if there is a surgery and we want to give rest for the colon. So that will be done. And a permanent, when we talk, permanent is permanent throughout their life. Okay, so when there are cancers or some injuries has happened and the patient need to be on a stoma, on a colostomy for permanent, then permanent is made. So the location, when we talk, it is usually ascending, transverse colon, descending or sigmoid colon. And according to the procedure, that's a single barrel, double barrel, and loop. So when we talk about loop and double barrel, this is in the ascending and the transverse colons. Single barrel means it is usually in the descending and the sigmoid colon. Okay, single barrel, why it is called it? There will be only one hole. Double barrel, there will be two holes. And the loop, I will just show you some photos. So I already told you about this thing. See, so single barrel and colostomy, otherwise we call, there is a hole over here. Okay, when we talk about the double barrel, there are two. One mucus will come, the other the fecal matter will come. And loop colostomy is just like that. The brace is put and this usually falls after about 7 days. We can remove this. So this is a loop colostomy. Loop colostomy and transverse colostomy is temporary. Okay, so this is ascending colon. This is the transverse colon. This is the descending colon and this is the sigmoid colon. Okay, so whatever is done from here to here up to this green marker, okay, that is temporary. So here we can do the permanent, but at times what happens, patient must have undergone a transverse colostomy, maybe temporary, but by days, after some time, what happens is become permanent also. Okay. So this is how it looks. I'll just show one photo. This is how it looks after the surgery. So there are a lot of indications: ulcerative colitis, Crohn's disease, cancer of the colon, obstruction, congenital abnormalities, injury, trauma, neurological conditions, fistula, etc., etc. Okay. So the so management we can divide into three: preoperative phase, postoperative phase, and rehabilitation phase. I'm sorry, I have a very bad throat. So that's in the preoperative phase, psychological preparation, counseling, stoma marking, and the ostomy visitor is very important. And the postoperative phase, the fixing of the stoma appliance, hospital discharge planning, and psychological preparation to adjust with the stoma. And the rehabilitation phase, of course, the follow-up, and of course, the evaluation of the stoma, what proper application they can use, self-care, nutrition guided, this all happens. It's a team approach. That's the first thing. So we have a enterostomal therapist, surgeon should be the hospital staff, like the staff who is working, the staff nurses should be their ostomy visitor, can be their family, should be their social worker. Whole team should be there when you talk to a patient or family. So preoperative phase, usually these problems are there because that's the first crisis phase where there will be a lot of disturbance for the patient, especially about the body image, poor self-concept, depression. They will have a lot of psychosocial problems and of course psychosexual problems also. Counseling is an integral part of the stoma care. So physically and psychosocially, we need to counsel the patient right from the first visit. We need to sit and talk to the patient and the family because they will have a lot of doubts that we have to clarify. So we have to sit and talk to the patients. Okay, and this is the time where we can provide we can provide the patients an opportunity to talk to us and explore what are the problems they are having, and we can help them in that way. Okay. The postoperative care, usually the type of that segment, what is used, the color of the stoma, how much it is protruded, if there is any, how the stoma is constructed, abdominal location, size of the stoma, if there is any edema, these things we have to go through. So this is a normal stoma. You see, this is how it will be protruded. A best pouch selection is a transparent pouch you have to select so that we can see the stoma also and we can see the fecal matter. Okay, so here you see there is an excoriation, some problem with the reason. If the patients are using continuous this one adhesive bags, this is what will happen. Okay. One thing keep in mind in the colostomy care, preoperative counseling, stoma site marking, postoperative care, and irrigation. That's what I said. Okay, it's a teamwork. And so let us go. Stomal color, we have to teach them. It is pink in color. Okay, tell them while wiping, cleaning, they have to be very careful because it may start bleeding. So very mildly, gently, they have to clean up. And if there is bleeding, ask them to give a pressure. Stomal edema usually occurs if they are using very tight and small pouches. Okay, so actually they have to use whichever colostomy bags, pouches they use, it should be of the correct size. Okay, and it should not be too tight also. Hernia and all, I'll come back. Usual nursing problems, what we face is irregular bowel action. The patient will tell you every now and then it is emptying. Some patients do have constipation, diarrhea. Diarrhea, usually, if the patient is having severe diarrhea, they should have to be hospitalized because they need to be hospitalized. And not only that, if there is dehydration, we have to rehydrate the patient. Excoriation of the skin, that is a peristomal skin. If they use this adhesive bags and all, every now and then removing, there will be excoriation. And in some cases, when there is leakage of the fecal matter, that fecal matter itself will cause excoriation, bad smell. And added to that is the psychological problems of the psychosocial problems. Because since when we talk about the skin care, wash just with soap and water, keep the peristomal skin, you have seen it. The skin we have to keep clean and dry. Correct size bag has to be used, and whenever the bag is 3/4 full, see that it is emptied. Okay. As far as possible, to clean the peristomal skin, ask them to use cotton washed clothes. Okay. If there is any fungal infection, they can use fungal ointments. Okay. Other than that, one more thing is apply carrier powder with egg white. So you forget about this carrier powder. What I will say is zinc oxide powder. If a rescoriation is the skin problem is the zinc oxide powder, you can make a paste with the xylocaine jelly or even our what to say cooking oil. Okay, and they can apply it. Okay, and avoid talcum powder and other creams on the peristomal skin. In the market, there are a lot of skin protecting agents are available. Okay, affordable patients can use it because it's very costly. The best thing is if they use the correct size bag and schedule their eating habits, what they should eat, they have to schedule it, how much they eat, the timing and all. A lot of these things is leaking and all we can prevent. Okay, so we need to teach the patient, and remember one thing, never to use any disinfectants and antiseptics to clean the peristomal skin. This is how they can clean it. Simple. Sexual life, support, advice, encouragement, and counseling. We need to sit and talk to the patient and the family that they can have a very normal sexual life. Okay, but it takes time for them to get adapted to that. Because here the patient's attitude is very important in maintaining a sexual performance. Okay, so as I said, it takes little time. We need to sit and talk to the patient and the partner. Okay, so they will have a lot of doubts which we need to sit and clear. Patients should be instructed to eat a varied and balanced diet. Experiment with new foods in small quantities. In the sense, don't tell them don't eat this, don't eat that. Okay, whatever they like, let them eat it. And if they find it's causing problems for them, okay, they can stop it. That's the best thing to do. Instead of you telling don't eat that. Okay, of course, you can teach them, tell them that things like non-vegetarian food, cabbage, cauliflower, onion, ginger, garlic, these things actually gives a lot of smell to the fecal matter. Okay. So if they reduce it in their food diet, the smell also will reduce. So that you can teach them and let them see what they have to eat and what they not to eat. And food should be always eaten in small quantities. Whatever they are eating, ask them to eat in small quantities. So that's what it written. Remember one thing, the same cooking oil has to be used, otherwise they will have diarrhea. Okay. Not experiment one day coconut oil, second day palm oil, and the next day sunflower oil. No. Throughout their life, let them use only one type of cooking oil to prevent diarrhea. Okay, so well-balanced diet, I said. And some more tips is eat a well-balanced diet, try new food, avoid gaining of weight, ask them to drink a lot of fluids daily. Buttermilk and yogurt is very good. Preventing blockage like nuts, seeds and all that, peas, salad greens and all, they have to be very careful use while taking, because this blocks the the intestine. Okay, the holes, it blocks it. These are the things which produces odor, like alcohol, cauliflower, eggs, fish, meat, baked beans and all, and certain vitamins and drugs, so that they can reduce or avoid it. Excess gas, as I said, cauliflower, cabbage, you can see broccoli, milk, onion, radish, these all things causes excessive gas. So balanced diet is best. And returning to as about 12 weeks after surgery, they can actually return to work. We say from once the patient gains back the health, the patient can start going for his job. Games they have to avoid, like football, cricket, basketball, rough contact games, all they have to avoid. Simple exercise they can carry out. You see, these things they have to avoid. But simple exercise they can do, aerobics and all they can do. Okay, because it improves the quality of life of the patient, because it improves the circulation. It makes the patient itself to feel better concentration the patient will have. The skin tone will improve. body shape will be there, they won't gain weight. Okay, and of course, they will have more self-confidence also. So help them to uh, try exercise, simple, and ask them to do it. Traveling, of course, they can do traveling, only they have to give extra bags with them while traveling. And of course, to prevent the stoma with the bag, especially when we are traveling in a crowded buses or in the train, because you know, in metro trains and it will be very crowded. So ask them to protect the stoma with their bags or with their books. Clothing, there is no restriction, but still I will tell, especially in India, some places are very humid, very hot. Better to go for cotton clothes instead of using synthetic clothes. And anything they can wear dhoti, they can wear jeans, they can wear anything they can wear. There is nothing like that they cannot wear. Anything they can wear. So the main thing is irrigation. So what we talk about the irrigation, when I talk, irrigation is done for the patients who are undergoing this one descending or sigmoid colostomy, not any other colostomy. Only if the patient has undergone a descending or a sigmoid colostomy without any diversion, they can go for irrigation. And irrigation is nothing, it's to make a regular bowel habit. So, see, this is how they do the irrigation. You can see, this is the bag where we will fill water in this bag. In this bag, we will fill water. Okay, and this bag, there is a funnel for this. You see, there is a tubing, and this funnel will go inside the patient's stoma. We can collect about 1 to 1.5 liter of water in this. Okay, expel the air and then insert it. Open the regulator, water will go. Before air entry, close it. Okay, so after that, it takes about 30 to 45 minutes for the return flow. Okay, for that we will use a long bag is that we will use. So the patient can do, meantime the patient can go do any work. So this is called irrigation. Now I'll just talk about irrigation. Irrigation is nothing, pushing, not pushing, we are entering some water, inserting about 1000 to 1500 ml of water into the colon, just like giving an enema. And this we will start after 3 weeks, from within 3 weeks to 3 months. Usually I ideally tell the patients to start after 3 months. Better, because they, by the time 3 months, they will finish all their therapy and all these things, follow up and all, and they will regain their health, and we can start off. Okay, that's the first thing. Second thing, the irrigation should be done every day at a fixed time. Half an hour and all, it is okay. But it's not like that today you did morning and tomorrow you're doing it in the night or in the evening. Nothing like that. It should have it daily at a fixed time. It has to be started. And for 21 days, first 21 days, regularly let them do it. By the time it will become a habit. But they have to continue it throughout their life. I repeat, it has to be started daily at a fixed time. Continue for first 21 days. That is within the 21 days, first 21 days, the bowel will get regulated. In the sense, when the patient does the irrigation, there will be a bowel movement. So the patient has to continue it throughout his life. It is just like giving an enema. So enema where we give in the rectum. So here what happens? There is no other way. So here we have to give through the stoma to clear the colon. So it will take about 45 minutes for the return flow. After that, the patient can go for his job. See, this is how it will be. We'll do one long bag is kept over here. And usually we don't allow the patient to sit in the Western closet. We ask them to this bag, they can keep it in a bucket. Okay, and once the return flow is finished, they can just empty that bucket into the closet and wash it off. We can use plain water, other than that, nothing. So this all I have already told you. Remember not to irrigate ileostomy. Ileostomy cannot be irrigated. Only colostomy of sigmoid colon or descending colon can only be irrigated. Funnel should be lubricated. You can take about 1000 to 1.5 liter of water. Okay, the patient can accommodate at 1 liter. Okay, only once it has to be irrigated at a fixed time. This is very important. Now, when you come to the bag, there already I said correct size bag has to be used, and it should be empty when it is 3/4 full. Wash the bags thoroughly with just soap and water. Not just washing with the hands, not using brush and all. Okay, and this has to be kept in the shade to dry, not to put in the sun. It is just like a rubber good. Okay, and one more thing is, don't put it somewhere down and all on the floor and all. It should be hanged somewhere. So some complications are there, which I will just want to show you. Pouch leaking. Why pouch leaking happens is usually if they don't use correct size bag, one thing. Second thing, when the stoma or the spout is very small or retracted, then there will be leaking. Okay, so the patient has to be careful in many things. So I'll just show some photos. You can see this is the excoriation. We have to reassure the patient. As I said, zinc oxide powder can be made a paste and you can use around the peristomal skin. Retracted. Here what happens? The fecal matter won't fall into the bag. So there will be this one leaking. Okay, so this has to be corrected. And usually happens if the patient puts on a lot of weight and all. Okay. And of course, we can use the convex bags for the retracted stoma. Prolapse, you see. Prolapse, if is there small prolapse, no, it gets recedes when the patient lies down. When the patient lies in a supine position, it will go inside. But big prolapse and all, it won't go. You see this prolapse, it's very difficult to recede back. Sometimes the patient has to go for a re-surgery. But at times, nothing can happen also. Okay. Now you see this is a prolapse. This one, hernia. Can you see over here? See, hernia. Something is pushing. This is a hernia. If it is possible, it can be corrected. Otherwise, the patient has to live with this. Bleeding, give a pressure. Stenosis. Usually, the stoma becomes narrowed many times, and sometimes inappropriate techno severe infection around the stomach can cause. See this one, prolapse. Nothing can be done. It's so big, we cannot do anything. This will automatically, when the patient lies in a supine position, this will go inside. This is a necrosis. Okay, so we need to teach the patient the color of the stoma. When if the sudden the color of the stoma slowly starts changing, immediately they have to report. This is a retraction. This is a hernia, already I showed stenosis. And this is the excoriation. You see how the skin is? Because of using a adhesive bags. So here you can put the this one, zinc oxide powder. Okay. These are some. You see, this patient has undergone a ileostomy. After that, the patient had a enlarged liver mets. Okay, and see how is it pushing, and the patient was finding it very difficult. So for everything we don't have any what to say, many things to do also. Sometimes when the patient comes like this, patient will ask you what I will do. You just think, look at this this one, that shape of that abdomen. It's very difficult to handle. Here, your communication, you have to sit with the patient. You have to see what are the find out what are the psychosocial problems, and then we have to talk to the patients. This is another patient. This one correct photo I will show you. See, the elaprotomy was done here and the bag was placed here. The stoma was here. Okay, but after some time, what happened? the fecal matter started coming from this also. It became a fistula like. That's very difficult. Patient is asking why. They said the fecal matter will come through this way. Now the fecal matter is coming through this way. So that was a failure of the surgery. So you see this big hernia. It's actually, no, it was not hernia. There was a recurrence of the tumor. The tumor has become so big and it was pushing, and almost it is closed also. This is also, you see the fecal matter coming through this way. We couldn't fix a proper back for this patient because of the shape, you see. This is another patient, ileostomy done. After that, it got blocked. The tumor was so big that the patient has to be done another colostomy here. So 2 openings. Can you imagine the psychological problem what the patient will be having, what the patient undergoes, the mental, what to say, stress. It's very difficult to talk to such patients because they were told that with one hole, everything will be fine. One was done and the other thing has also come. Okay, so thank you so much.
Thank you so
Yeah,
much.
I think I finished in time, on time. Huh?
You're before time, I think it's just 3:30.
Okay, before time. Okay.
If you have any doubts, any comments, or anything else to add on?
Yeah, first we can take that, then we'll go for the presentation.
I'm doubtful about the presentation as our participants has not yet joined. Yes.
We need to wait or what?
Let's go for the comments and doubt clearing session first, I think, ma'am. If you have any questions, please. If you are facing some language issues, she could help with you that. Like,
they all are from this one.
She know Hindi, English, Malayalam, and a bit of Tamil, I think.
Hello, I can see Carol, Shika Pradhan, Evangeline Maria, Priya, Nancy. आप लोगों को कुछ पूछना नहीं है? Have you people, or you people all are working in some cancer institute या और कहीं? कभी stoma देखा है? Anyone can answer. Have you seen a stoma anytime? Colostomy patients? Kanchana, Bindra to everyone. Yes. Yes, Kanchana. Good. So do you have any questions to ask? Do you have any doubts? You can ask. That's no problem. Yeah, Sunita. Yes, ma'am. Yes, ma'am. Kulasi Tupono. Yeah, good. So you people have come across the. So I would like to ask, have you seen any patient doing irrigation for colostomy in your place? कभी देखा है कि irrigation कर सकता है? No, ma'am. Kanchana. Very good. Kanchana, आप कहाँ पर काम करते हो? Nancy, Ulsi. Okay. Can you just tell me where you are working? Vinita.
I think Kanchana is from Ludhiana, Punjab. Mohanda was
Punjab. Acha. MES Perindalmanna. Okay, Nancy Joseph. Good. तो आप लोगों ने कभी देखा नहीं है कि irrigation कैसे करता है, right? ठीक है, एक्चुअली जो पेशेंट है ना डिसेंडिंग सिग्मोइड कॉलम कोलोस्टोमी अंडरगो करता है, वैसे पेशेंट्स को हम कर सकता है. This is irrigation करने से there is one benefit, that is the patient after doing the irrigation till the next day nothing will come out till the patient does the irrigation again. This is just like an enema. We are giving water inside, all the colon will get emptied. So the patient can just place a small bag and go for his work. Next day again the patient can do this irrigation. That time only the fecal matter will come. That is the benefit with this. Only the thing is the patient, we need to teach the patient, educate the patient. So usually what is done over here is patient is admitted for 3 days and then we teach the patient We see how the patient is doing it. They also demonstrate it, and then we will discharge the patient. So the patient can have a very normal life. That is very important. Patient continues to have a very normal life. They can live. They can get married. There is no problem. They can go for their job. They can go for any function. But of course, in ileostomy or in transverse colostomy, we cannot do anything. But of course, you can teach them to schedule their eating habits, in the sense they can eat a full breakfast in the morning, no problem. They can have good lunch also, no problem. But the dinner should be taken at least before 7 or 8 o'clock. Before 8 o'clock, I used to say before 7, that is the best thing. Why, in an ileostomy patient, after the patient eats, maybe within 1-2 hours, that starts emptying. So if the patient eats in the evening by 7 o'clock, it will start emptying. Okay, so by 10 o'clock, it is empty, the patient can go for a good sleep. But if the patient is taking a late dinner, whole night the patient has to sit. One thing. Second thing, ask them to take a very light dinner in the night. Ileostomy patients has to take a lot of fluids because they will have dehydration. Because from the ileostomy, the effluent is very watery. You all know, in the ileum, this fecal matter is in watery. Okay, then it goes to the transverse colon. There it becomes little bit mushy. By the time it reaches the descending colon, the stool is formed. Ma'am, Shagundala is not present, so we can ask someone else to read out that can be done, no problem. Okay, so the patients who are undergone a ileostomy and a transverse colostomy, ask them to schedule their eating habits. They have to drink a lot of water. But the evening time, evening in the sense I said by 7 o'clock, let them take a very light meal in the night, and also whatever fluids they are taking, let them reduce it, so that before they go to bed by 10 o'clock or something, everything is emptied and they can have a good sleep without any disturbance. That you have to teach them. So many times this happens, the patients, usually what they do is, not patients, every person have a habit of eating too much in the night, in the evening time, dinner. So that we have to talk to the patient and tell them to reverse it in this way. Breakfast, let them have, and whatever they are eating, let them see what they are having. And if they find with this food I am having some problem, let them stop that food, instead of we telling them to stop that food. Okay. Sini, anyone can read it out, or I need to read?
Anyone from the participants can read it out, ma'am.
Yeah. So tell them, anyone, you can tell anyone to read that. Yeah, ask Kanchana or someone. So many.
Kanchana, can you please read out the case presentation as our participant is not present?
Hello. Kanchana, are you there? Unmute.
Yes, ma'am. Okay, Kanchana, I will be sharing it now.
Yeah.
Actually, this is the case presentation by Ms. Shagundala. She is not present here. So, Kanchana, please.
Okay, ma'am.
This is from the LDH and all, it is written, which place? MOH, Ministry of Health.
Carcinoma tongue.
Okay,
Kanchana,
so Kanchana, can you read it?
Yes, ma'am.
Yes, go ahead.
Ma'am, can I see the first slide?
Yeah, first slide is, this is the first slide.
Mr. I cannot identify. Mr. X, age is 6 years, male, diagnosis carcinoma tongue. Next slide, please. presenting complaints was the patient was presented with difficulty in taking solid and semi-solid food items, ulcerative growth present over left lateral side of tongue, respiratory distress, and UTI. History of illness was the patient was presented with a diagnosed case of carcinoma tongue involving left lateral and posterior 1/3 of tongue crossing midline, measuring 4.5 into 4.1 into 5.5 centimeter. Laterally left, extensing muscle involved. Genioglossus involved, hypoglossus involved, gem white involved, ling neurovascular bundle involved, sublingual space involved. HP shows SCC squamous cell carcinoma. He was diagnosed in November 2021, but he did not take any treatment. No comorbidities. Family history was no history of any comorbidities in the family. Physical examination, height was 160 centimeters, weight 60 kg, BP was 150 over 90 mm of Hg, pulse was 100 per minute, temperature is 98 degree Fahrenheit, respiration is 34 per minute, SpO2 is 98%. General examination, conscious and oriented, no pallor, no icterus, no cyanosis, no edema, no journalized lab. Systemic examination, chest, bilateral air entry equal. Ma'am, I am unable to see the slide. Treatment and significant investigation was treatment tracheostomy done on 2nd February 2022, Riles tube inserted. IMRT treatment started on 10th February 2022. Intent of treatment palliative. Patient managed conservatively with IV fluids, analgesic, antiemetic steroids, hepatoprotective drugs, painkiller, morphine, antacid, and other supportive drugs. Suctioning care given. Palliative, it was 25 palliative RT. Significant investigation was COVID antigen test, HBsAg, HCV, HIV, and blood culture. This is the investigation chart.
Skip first. This you can skip. Next one.
Yes, ma'am. Psychosocial aspects was he is a 60 years old man living with his son and daughter. His wife died 5 years ago. No one else in their support to long-term treatment. His sister came to help him on and off. He has his own business, but it is not able to keep it up with it because of Angie tube and tracheostomy tube. He was not comfortable to go anywhere to meet anyone, which increased his anger and irritation. He left lonely without his partner. Medications: tablet Colimax MD 0.25 mg SOS, tablet Wobran G TDS, tablet morphine 150 mg BD, sachet Racetol once a week, Dulcolax Post once a week, candid mouth pain, and steam inhalation. Main concern: care and communication, education, pain, apprehension, positivity, listless, UTI. Summary: he is a 60-year-old man with a case of CA tongue, floor of mouth is extended to the oropharynx stage 4. Patient was having difficulty in swallowing before since 2 months and was hospitalized for this. During hospitalization, angine session was done and due to breathing problem, tracheostomy was done. Symptomatic treatment was given during hospitalization. Patient planned for radiation, so palliative radiation given. Discussion point was what can be done for his what can be done for this patient, what are the problem faced by the patient, how to motivate the patient, nutritional build-up, pain management, family counseling. Thank you, ma'am.
Okay, okay. Keep this discussion points. I would like to ask this Shakuntala, anyone working in that same institute of Shakuntala here in this
Yes,
group?
ma'am. I am also working with Sri Kuntala.
Ah, so you're working with Shakuntala. So do you have a palliative care there?
Yes, ma'am. Palliative care unit. We have no different palliative care unit there. We are planning for this, but not yet.
Okay. So who is prescribing morphine and all for this patient?
Ma'am, treating consultant.
Acha, he has done his palliative course, huh?
No,
Okay.
ma'am, they are oncologists and they are in palliative. They are doing palliative treatment.
Acha, they have not done any palliative course and all. Acha, because it is written 150 mg of morphine. I don't know what type of morphine was given, SR or what. Okay, anyway. What can be done for this patient? Because what are the problems? So first we'll come. What are the problems faced by this patient?
Ma'am, first of all, patient is feeling loneliness without his life partner.
Yeah.
We have to counsel as patient is spiritually patient is not built up as he feeling ki I cannot meet with the patient people with NG tracheostomy. So patient counseling is the first main concern in this case.
Yeah, so the first and foremost is we have to sit and communicate with the patient and the family, because daughter and son, someone is there to look after them. Okay, so we need to
his
sit and
sister is
talk to
also
them.
supporting to him.
Okay, and the next thing is taking care of the patient and taking care of the other things. Okay, so he's feeling irritated.
His business is also disturbing because of him. He is not able to go to their business.
Yeah. So actually, he need to give his business to his son. His son has to take over the business and look after that. Okay. So before that, why we have to communicate with the patient? First and foremost, he may be feeling a little bit guilt also that he had the problem since 2021, but he never went for a treatment. Okay, now only he came for a treatment, and by the time he reached up into the tracheostomy. So that is one problem. So we need to sit with the patient and the family, talk to them, and especially how to take care of the other things. So one thing, anyhow, he's having a rice tube. So in the rice tube, we have to teach them how to give a rice tube feeding and what all can be given in a rice tube feeding. That's very important. Okay. Any idea what all can be given what we can give through the rice tube?
Ma'am, we can give liquids, right? Like black chana liquid, moongi dal ka pani.
जी हाँ वो correct है correct आप जो बोल रहे हैं, instead of buying this ensure and protein food and all, जो भी घर में है we can make it. ठीक है, जो भी घर में, जैसे कि आपने बोला मूंग दाल, चना दाल and all. So what I mean to say is, because others also there जो हिंदी नहीं समझता है ना, हम लोग उनसे उनके लिए भी बोलना पड़ेगा. Patient can have whatever is there made at home, all types of dal. Okay, that we can cook it properly. Even we can grind it in a mixer, take out that water and give to the patient. We can make egg flip, chai, we can make tea, we can give coffee, but a little bit. Okay. Then this one, chicken soup we can give, mutton soup we can, if the patient is taking that. Egg flips we can give. If the patient is a vegetarian person, then we cannot give these things. So whatever is made at home, that we can give to the patient, and this should be given, ask them to give every 2 hourly, at least 200 to 250 ml, not more than that. Okay?
Yes,
okay. So this thing we have to teach the patient and the family. That is one thing. Now the second thing is, patient is irritated, very right, because he will have one thing, he has lost his partner. Second thing, he must be feeling a burden to his family. Third thing, as he said, his business is not going well. Fourth thing, he never took a treatment in the proper time. So this all must be there in his mind. Okay. So, but if you sit and communicate with the patient, talk to the patient, slowly he can come up with that. Okay. And of course, the way how we are going to take care of the tracheostomy and these things, maybe the patient can go and sit in the, actually with the rice tube, we can just cover it with the mask. Okay, so rice tube won't be visible. Tracheostomy, already we say how to take care of a tracheostomy. So what type of tracheostomy is using, the plastic one or the metal one?
Both, ma'am.
What?
Ma'am, both we are using.
No, for this patient I am asking.
Ma'am, mostly we are using plastic.
Plastic also, okay. So whatever it is, teach them how to clean. So cleaning the skin around the this one, tracheostomy tube. Okay, that is very important. The second thing is, it should be always covered with a wet cloth. Wet in the sense, not too much of water. Make it wet, squeeze it, and it should be covered. Why it should be covered? Kanchana, why it should be covered?
To
prevent flies. Yeah. Not only flies, dust. That is one thing. Second thing, हम लोग हॉस्पिटल में जो ऑक्सीजन सिलेंडर के लिए पानी रखता है ना, स्टेराइल वाटर.
Yes, ma'am.
Because the cylinder is having dry, dry
to moisturize the air.
Moisten the air. Yeah, very right. So one nice clean cloth, they can just squeeze it nicely. Pani mein duba ke na, just squeeze it nicely and just cover it well. Okay, to prevent this. The other thing is, we can teach them how to speech therapy. Another one is speech therapy. So how we teach them speech therapy? Ask the patient to take deep breaths like this. Then ask the patient to, with one finger, to close that hole. The tracheostomy tube hole is there, na? Just to close it. Okay. Uske baad, tell the patient to talk. Trying to talking. Okay. So if you are sitting like this, patient, if such patient saying dard hai, in the sense pain, we ask the patient dard. So you will tell okay, slow, because when they talk, because there will be a whistling sound coming. Okay, maybe he will be able to talk. Some patients may not be able to talk. Okay, so ask them whether they can try for a speech therapy also. So you can teach them how to talk. Another thing is, they can write and show you that what are their problems. That is the second thing. Whatever problems they are facing, they can just write and tell you that these are my problems, because he can hear. Okay, so in that way also you can talk to the patient. Then one more problem is, problem in the sense it's not a problem. What we have to prevent is, the patient can go for shaving and all, but tell the patient to be very careful if that that hair and all falls inside. While washing the face, he has to be very careful, because what will happen while washing the face, that soap water can go inside. Okay, so he has to cover it properly before doing all these things. Okay, and ask him never to remove the tube. If you remove the tube, then he's going to have a problem. Okay, so he should never remove the tube. And whenever he's feeling cough, and I'll ask him just to hold the tube like this when he's coughing, because there are chances for the tube to come out. Okay, yeah, it will come out. Okay, that is another thing. Okay, and a patient can take bath and all here and all, no problem. Now down portion he can take bath, but if he's taking a head bath and all, he has to be very careful that water should not go. So he can bend, someone can help him to take the bath. And if there is secretions, some patients do complete lot of secretions will be there. So then what you will do? What can be done if the patient is having a lot of secretion and the secretion is thick? Suction, Parsley Thomas. Yeah, suction if the patient is in the hospital. Little more things we can think of. Chest physio, right? Chest physio we can teach. Steam inhalation, very good. Sunita Mahato has written steam inhalation. Even at home also they can take a steam. And now steam is not been taken here, it should be taken here. Okay. So steam inhalation, as they take this, secretions will become little loose and it can come out. And even you can help the patient, ask the patient to hold the tubings like this, and they can You can ask them to do little bit of coughing. So what happens that comes? Chest physio, you can teach them. Okay, these things can be done. In this one, I saw Dulcula suppository is written every week. Why? Kanchana or Shakuntala?
Ma'am, as I have read the presentation, but I haven't discussed with Sister Shakuntala.
Okay.
If patient, as I assume, as patient is taking his diet properly, there is no need to give suppository on weekly basis.
So what I found was patient, because the patient is in morphine. Okay, morphine
Yes,
usually causes constipation, right? Sunita is telling, yeah, right. Morphine usually causes constipation. But giving once in a week the suppository, I don't think it is going.
Contraindication, ma'am.
Pardon?
If weekly suppository is not a contraindication.
It is not a contra, and I'm not talking about a contraindication. Actually, 150 mg of morphine and all, if you can talk to the patient, you can ask them, he will be constipated, otherwise he will be having a hard stool. So for one week he won't be passing properly. So actually the patient needs some Dulcolax, that is Bisacodyl. Bisacodyl daily, if the patient takes, at least he will have a daily bowel movement. Okay, so you will have a class on constipation, they will tell you. Okay, I told you this because patients who are in morphine, they will have constipation. So
Yes,
for 1 week, if the patient waits, it's a difficult thing. Okay, if the patient is put on some Bisacodyl daily, HS, 1 in the night, patient will have daily bowel movement. That can help the patient.
Ma'am, we can proceed like as cremafin syrup.
Yeah, cremafin syrup is also good because it softens the fecal matter. So the patient can have a mirror. So in this case, you can just talk to the doctors also, ask them if they can put these things. Okay.
Okay, ma'am.
Okay. So how to motivate the patient? See, motivating the patient, see, with communication only, you can do all these things. You have to sit and it won't take in one sitting, it won't happen. Okay. So whenever you have to take 2-3 sittings with the patient, and if the patient is going back to home, there should be a home visit follow-up also, where you can directly see what the patient is doing at home, how you can help the patient. Okay, maybe if the patient comes out of this one, the patient can go and sit in his shop also to do the business. I don't know what business he's doing. If it is a shop, and the patient can actually go and sit over there, help his son. Okay, that much time he can spend over there. Okay, so communication is very important so that we can motivate the patient. Okay, and also how to take care of the patients, the other things like cleaning these things, about his food and these things. So a lot of things we can handle. Okay, nutritional buildup, I told you already what has to be given to the patient. So if we give all this protein food, protein in the sense what I'm talking about, this dal and these things, it's a high protein food. Okay, patient can build up his body also, in the sense there won't be any malnourishment in him, because the patient is in Ryle's tube. But every 2 hours, we need to feed for the patient. That is very important. Otherwise, you won't have enough of fluid inside. Because in a whole 24 hours, at least 2.5 to 3 liters of this one fluid has to go inside the patient. Okay. So with the feeding, whatever we are giving, we have to see that the patient is getting this much ml. So within 24 hours, if you give every 2 hours, we can manage. And last feed in the night by 10 o'clock, they can give. In between, if the patient's family is getting up, they can just give plain water somewhere around 2 o'clock or something. Then again at the morning, 6 o'clock, they can start. So it will be somewhere around 2.5 to 3 liters. Pain management, already the patient is in 150 mg of morphine. Okay. I don't know what type of morphine is being given, whether SR the patient is taking or whether the patient is taking IR. IR is usually given 4th hourly. SR means, of course, it is, but 150 mg, I don't know exactly how it is being given, what type of morphine is given. Here, back in our places and all, we give regular morphine which is given every 4th hourly. Okay. SR is given BD, that is being shown, but 150 mg SR, I don't know about it. That's what I was asking. So pain management has to be done for this patient. Sit and talk to the patient, ask the patient to write where the patient is finding pain, which area, what the side, whether the patient is having pain due to this tracheostomy, or the patient is having somewhere else some other pains. Okay, so we have to find out about the pain. Means again, you will be taken, pain management will be taken, so you'll come to know the patient quality of the pain, the intensity of the pain. We need to know the sites where the patient is having, we need to know, and accordingly then we have to put the patient on the drugs. Okay, family counseling, of course, it's very important. Need to sit with their children, talk to them, tell them that what his father is going through and how he's missing his wife and how they can help the patient. Okay, and ask them also whenever they are at home to talk to the patient, not to isolate the patient, put him in one corner of the house where nobody is going and talking to the patient, only showing their face whenever they are giving the feed. Okay, and especially daughter is looking after, and otherwise daughter-in-law is there. Teach them how to give the feed correctly, 2 hourly, how to give the feed, how to aspirate it and see, because the patient should not die with aspiration also. Okay, because it should be in the situ. So if we teach them how to aspirate and see whether the tubing is in the position, how to give a feed, that is very important. Like what we say, plain water to be given, then you have to give the feed, then you have to, air entry has to be prevented. Okay, and the patient always in a sitting position, that is semi-fowler's or fowler's position, the feed has to be given. After giving the feed, see that the patient is put in a side lying position, not in a supine, but supine itself, but on a side lying position the patient should be. Okay, so immediately after giving the rights to, the patient should not lie down. Half an hour let him be sitting, then let him lie down on a side lying position. So taking other thing is like bowel movement, that is very important. Just talk to the patient whether he is having a daily bowel movement, what was the pattern first. If the patient says I was passing every day, then we need to think of giving the patient daily bisacordial so that he will have daily bowel movement if he is having problem. Actually, Shakuntala is not there, otherwise we could have asked why the patient is given once in a week only the Dulcolax suppository, that also. Okay, that was very important question. Sinia, can you go to the previous slide, please? Again, one more. Again. Yes. See, the steam inhalation already it is there. Candid mouth pain. So another important thing. A patient who is having a Rayleigh tube and a tracheostomy needs a good mouth care. So teach them how about the mouth care. Patient needs at least every two hourly, patient needs to take care of the mouth. So ask the patient to rinse the mouth every 2 hourly with a normal saline. You can teach them how to make a normal saline. Ask them to just swish out. Okay, that is gargle it, okay, but not to swallow it, not to drink it. They can just wash the mouth every 2 hourly, clean the mouth, and they can. Maybe the patient is having this one fungal infection. Okay, means candidiasis is there. That's the candid mouth paint is given. So they are not taking care of the mouth. Because the patient may be thinking, I'm not taking anything, eating, then why? No. So as a nurse, you people very well know that mouth care is very important in a Rayleigh tube patient. So teach them how to take care mouth care. Very careful, tell them not to swallow the water. Okay, just gargle, throw it out. Okay, so anyway, patient is in Vovaran also, morphine also. This part, I also don't know what it is exactly, why it is been given under steam inhalation in your patient. At home also, you can teach them at home how they can take a steam inhalation. Okay. So anything else?
Thank you, ma'am. I think you have discussed all the aspects of that case presentation. If any participants have any doubts, you can ask it now also. Please make use of it.
Hello, ma'am. Regarding irrigation, ma'am.
Yeah.
Regarding irrigation, ma'am.
Yeah, tell me.
First, yeah, first 21 days we doing continue, ma'am. After that, कितना दिन के बाद फिर करना पड़ेगा?
पहले 21 दिन करने से दैट रेगुलेशन कम्स, ठीक है, बाउल मूवमेंट का रेगुलेट हो जाता है, लेकिन पेशेंट को रोज करना पड़ेगा, जब तक पेशेंट जिंदा है रोज करना पड़ेगा।
ओके मैम,
समझ में आ गया?
यस मैम, ओके।
जब भी वो पेशेंट इरिगेशन करेगा तभी फीकल मैटर बाहर आएंगे, नहीं तो नहीं आएगा। ठीक है, लेकिन ऐसे भी टोपाना, यू आर फ्रॉम विच प्लेस, आप कहाँ से हो?
मैं मैम ये रक्सौल बिहार।
बिहार से? अच्छा अच्छा अच्छा, बिहार।
यस।
आप कैंसर इंस्टीट्यूट में काम कर रहे हो?
नो मैम।
फिर कहाँ
नो
पर
मैम,
काम कर रहे हैं?
जनरल हॉस्पिटल है ये मैम, डंकन
हॉस्पिटल, गवर्नमेंट हॉस्पिटल है?
नो मैम, डंकन।
अच्छा,
प्राइवेट हॉस्पिटल।
प्राइवेट हॉस्पिटल है, प्राइवेट हॉस्पिटल।
यस मैम।
बिहार कौन सी प्लेस है? दरबंग?
नो मैम, रक्सौल।
रक्सौल में? अच्छा, रक्सौल में। अच्छा, बहुत सारा पैलिएटिव सेंटर्स आया हुआ है बिहार में, पटना में है, दरबंग में है, फिर मुजफ्फर में है, बहुत सारा आया हुआ है। ठीक है
जी जी।
तो लेकिन एक बात है टोपना कि
जी मैम,
ये इरिगेशन सबके लिए ना, आप लोगों को एक एक्चुअली फिजिकली आप लोगों को ये सीखना है।
जी मैम, यहाँ तो अभी ये अवेलेबल नहीं है मैम, बस ओस्टोमा केयर तो बहुत रेयर होता है मैम होने का।
रेयर होता है। अच्छा ठीक है।
जी जी।
नहीं, लेकिन कभी भी आप लोग को कुछ डाउट था, पार्लियामेंट में बुला सकता है, उन लोग आपको गाइड भी करेंगे।
ओके मैम।
ठीक है, कुछ भी डाउट है तो कर सकता है, लेकिन इतना ही है इसमें, पहले 21 दिन करने से वो बाउल रेगुलेट हो जाता है, लेकिन अब जिंदगी भर उन लोगों को करना ही पड़ेगा।
ओके।
लेकिन बात इतना बेनिफिट है कि एक बार सुबह उठ के उन लोग करेगा, सुबह या मतलब उनका जब टाइम है, लेकिन हर दिन एक ही टाइम में करना है, बस इतना है। ठीक है, तो उन लोग सुबह अगर एक टाइम में कर देगा, फिर दूसरी दिन जब उन लोग इरिगेशन करेगा तभी फीकल मैटर बाहर आएगा। यही एक फायदा है।
जी मैम, थैंक यू।
लेकिन ध्यान रहे ओनली फॉर डिसेंडिंग सिग्मोइड कोलन पेशेंट के लिए, कोलोस्टोमी के लिए ये कर सकता, और कोई कोलोस्टोमी के लिए नहीं कर सकता। ठीक है
जी मैम, थैंक यू।
Any other queries?
So nothing is there, mean we can close.
Yes, I think, ma'am, if there are no other comments or questions, we can wind up for today.
Okay, Sami.
Thank you, ma'am. Thank you so much for being here. I know this is official, but anyway, thank you so much.
And thank you all the participants. Okay.
A special thanks to Kansan for reading out that and helping out with the case presentation. Thank you all. We'll see you on the next session. The feedback link will be shared in your WhatsApp group. Thank you, ma'am. Thank you so much. We'll see you. Bye.